Thanks so much for the invitation to come out. I want to specifically thank Anne and Jason for making this happen. We had to sort of took a little while to come to a date, but I am just thrilled to be here today to share with you part of my journey, which in many ways mirrors many of the things that certainly someone like Stan was quite inspiring to people like me in terms of our not only our mutual interest in classical hematology, but our passion for leadership and mentorship. So what I'm going to do is take you on a journey of where we are with sickle cell disease, looking at this through, I think, hopefully an interesting lens. And these are my disclosures. This was my inspiration for my talk, and I think probably some of you have seen this monument in Washington, D.C. of Martin Luther King. And an important inscription on the monument, and that you've probably heard, is the quote that we shall overcome because the arc of the moral universe is long, but it bends toward justice. This is important inspiration for me because this was stated and was intended to give people hope at a point in time in our country where there was amazing amounts of uncertainty, amazing amounts of instability, including political violence, much of what we are seeing right now. And so to the extent that we can sort of look at that lens and to be hopeful and looking forward is what I'm hoping to describe today. So what I hope to cover is a reflection on recent scientific advances in sickle cell, including gene therapy. Sickle cell is the study of the complexities of race and science, and then opportunities for moving forward. What I hope to do is to take that same concept and ask the question, in the long biomedical arc for sickle cell disease, and to bend it towards health equity. I also think about the concept of Sankofa. Sankofa is a metaphorical symbol of the Akan people in Ghana. And what it literally means is go back and get it. And it is usually depicted by a bird who is picking up an egg off of her back. What it means is it emphasizes the importance of reaching back to knowledge that was gained in the past, bringing it into the present in order to make positive progress. Sickle cell disease has been remarkable in terms of how it has mirrored advances in science. I think many of you, I hope many of you are familiar with this. This is an amazingly simple single point mutation, genetic mutation, the beta globin gene that results in really a profound condition. It's inherited in an autosomal recessive manner. It affects about 100,000 Americans, but millions of people globally. Newborn screening where available, it certainly has been available in the United States. The majority of my career clearly can reduce morbidity as well as mortality. But the disease, while fundamentally a hemolytic anemia, causes amazing widespread damage. It's also a challenge, and in many ways a very rewarding challenge, in that not only are there acute manifestations that are often emergencies, but it really requires attention long-term to its management. That single point mutation changes the characteristics of hemoglobin such that it polymerizes intracellularly under certain conditions, causes that classic shape change in red cells, and then many of the other things that are attendant to that. The arc started well before recent times, and most people tie it to 1910 when there was the first description in the Western literature of sickle cell disease. For decades after that, this was really an amazing period of discovery where researchers like Stan and his colleagues really laid the groundwork for much of what we understand, not only about sickle cell, but other parts of classical hematology, and I dare say science as a whole. But what I'm going to focus on is on the last decade, where I think we've really seen an acceleration in the science, and hopefully now seeing some opportunities to actually translate that into improvements that matter to patients. And while we have a lot to say, I think that it's very important, though, to frame this in terms of looking at our opportunities. Because while we have continued to see an improvement in the life expectancy of all Americans, while we had a very flat curve for sickle cell for the better part of the first 60, 70 years that we knew that sickle cell existed, we have had some important measures that have seen that curve increase, the trajectory of that red line. Yet there is still a nearly 3-decade lag between the survival or the life expectancy of Americans overall and those who have sickle cell disease. So clearly a gap that we need to continue to work to close. It's particularly important in this being the Department of Medicine because I'd like to sort of pat myself on the back like my other fellow pediatricians because we have really seen the needle change for children. Yet when we think about sickle cell disease right now, the excess mortality is in young adults. And so really the opportunity to really make an impact on this disease, while we continue to see opportunities in pediatrics, it will really be among my colleagues who do classical hematology as internists that really are attacking the biggest part of the problem. This was looking at the period from 1999 to 2009. I will show you that we still have work to do based on data that's even more recent than that later in my talk. But again, this is a disease that while it's a single point mutation, it causes amazingly widespread damage, both acute and chronic complications that really involve almost every organ system that one can think about. And so this is really where the challenge lies, to not only have classical hematologists, but to also have specialists across all of medicine to engage, to understand their roles in managing people with sickle cell disease. Hydroxyurea has become the backbone of treatment for sickle cell disease, and I credit my colleague, Dr. Russell Ware, for compiling all of this. But there are a couple of really key take-homes on this slide. So this is a continuum looking at many of the clinical trials that have informed our understanding of how hydroxyurea can be used in sickle cell. But there are a couple of things that are really important. We established a proof of principle in a series of adults in the 1980s with the approval by the FDA for use in adults in 1997. But I think if you fast forward all the way across that arrow to from 1997 to 2017, this is a really important period because during this period, there were no additional agents that were approved for sickle cell disease. And so if you can imagine any of the other diseases for which we've made progress, whether it's diabetes or cancer or heart disease, when you are only looking at such a profound disease and you only have one agent that's approved, it is not surprising that progress is slow. Another thing my addition to this slide is the asterisks that are out on one side for the specific clinical trials, because these are noteworthy. These are trials that were either partially or entirely executed in low and middle income countries. This is so important because that really is where the burden of this disease lies. It also refutes whatever concerns people have about trying to engage in these regions of the world to look at fundamentally looking at whether or not the same processes, the same effective therapies that we see in the US, being able to demonstrate that they can also be used safely and effectively in places that also matter. There are a few other choices in therapy, including not only hydroxyurea, but also L-glutamine, which was approved in 2017. Voxelotor and crizolizumab were approved in 2019. They each work in slightly different ways. L-glutamine by actually reducing oxidative stress on red blood cells. Voxelotor by actually binding to alpha globin and improving the ability of hemoglobin to actually retain oxygen. And crizolizumab is a P-selectin inhibitor, so hopefully reducing the adhesiveness of red blood cells. They are given in slightly different ways. Unfortunately, Voxelotor was removed from the market globally about almost just over a year ago. There will be some discussion about Voxelotor and some newer data on that at the ASH meeting this year, because there are considerations for returning it to its use in sickle cell disease. So this list, though, is improved, but it's still relatively small. I think what makes me hopeful, though, is there are over 30 agents that are currently in the sickle cell disease therapeutic pipeline. That is a given. With sickle cell, like most conditions, many of these will not make it to the market. But the notion that we can continue to see investments in sickle cell disease at this level is so important if we are to continue to look for opportunities to advance not only the lifespan, but also the quality of life for individuals with sickle cell disease. What is this translated into? Well, drug treatment, again, hydroxyurea being the backbone of that, but certainly some other agents. Allogeneic stem cell transplant, which I'll touch on. But I'm also going to spend a fair amount of time talking about ex vivo gene therapy and the future, which I really believe is going to actually rely heavily on in vivo gene therapy. Curative therapies in sickle cell fall into two big buckets: hematopoietic stem cell transplants that are primarily allogeneic. The most experience that we have are with match-related donors. I'll point out that the very first child with sickle cell disease was cured of this disease, not because she had sickle cell, but because she had AML and was fortunate enough to have a sister who matched, and she is alive and well today. But we've certainly made advances with unrelated donor transplants and now haploidentical transplants that are usually other family members. Gene therapy is not one thing. The three forms that I'm going to talk about today are gene addition, gene editing, and base editing. So when we talk about curative therapies using allotransplants, this is data from Eliane Gluckman, and she was able to actually look all the way across the continent. So this is 1,000 patients who have undergone curative therapy with matched sibling donors with sickle cell disease. I think at this point, given how low the cumulative incidence of chronic graft versus host disease and how high the overall survival is, there really should no longer be questions that those who have severe sickle cell disease should be offered curative therapy. In my institution, if you require transfusions with any frequency for sickle cell, you should be HLA typed. We should know whether or not you have a sibling donor. Because certainly there should be fewer questions about whether that is something that should be considered. If you are severe enough to require that degree of intervention, surely there should at least be a conversation with you and your family about the potential for cure. There certainly are people who are going to do better than others, those who are younger than age 14, and those who are being done more recently. So since 2006, we've improved supportive care. And largely because of improvements in supportive care, we again are also seeing better outcomes. We're seeing slightly better outcomes if we're using bone marrow or cord blood. But clearly, I think at this point in time, these patients should be referred for a conversation with a transplant specialist. It's worth noting, however, that most patients with sickle cell today will lack a suitable matched or an unrelated donor for a potential. So that, I think, is something we have to consider. And that has formed the framework for considering gene therapy. Now, when we talk about gene therapy, though, I would be remiss if I didn't touch on haploidentical transplants, which many of us thought was really, surprising that we would see results where there's only a partial match, usually from either a child giving to a parent or a parent giving to a child. But this is fairly recent data. That's a multi-center study that is actually looking at haploidentical transplants using extended post-transplant cyclophosphamide for immunosuppression. And the results were really, really remarkably good, with a 2-year event-free and overall survival of 88% and 95% respectively. So really just an extraordinary accomplishment there. The results of certainly a rate of a chronic graft versus host disease, which is high and not trivial. But the results for pediatrics is not quite there, but clearly an approach that certainly deserves further consideration. Gene therapy with sickle cell disease is currently always ex vivo. And so that cells are taken from the body, they're modified in the laboratory, and then they're returned after chemotherapy preparation. And there are a variety of different applications for this. One approach is to add a normal beta globin, because that is certainly the gene that is abnormal in sickle cell disease. And as long as the expression of protein from that treatment is pancellular, functionally, it would convert someone from having sickle cell disease to having sickle cell trait, a condition that we know is associated by and large with no symptoms for the most part, and a relatively normal lifespan. And so certainly it would be, in many people's eyes, a very acceptable outcome for something as extraordinary as gene therapy. Another approach is to increase fetal hemoglobin, because fetal hemoglobin is non-sickling. This can be done by adding a copy of a gamma globin gene, by modifying beta globin to make it more gamma-like, or by altering the expression of a gene that is not a globin gene, but that does affect the regulation of, for instance, fetal globin expression. And so again, it has fallen into multiple different categories, and I'll describe for you those for which we have meaningful clinical data. The first is one using LentiGlobin BB305, which is a replication-defective, self-activating lentiviral vector that produces hemoglobin A that has a single additional mutation that results in an amino acid substitution called T87Q. This is a cartoon of the LentiGlobin vector that is being used, and you'll notice that it includes the beta locus control region, which is the normal, natural, erythroid-specific controlling mechanism in our red cells. And so this makes this erythroid-specific. That amino acid substitution, T87Q, that T to 87 actually is naturally occurring in gamma globin. So this is an example not only of beta globin, but making it gamma-like. It inhibits polymerization because fetal hemoglobin naturally is non-sickling. It also allows us to use HPLC to be able to monitor transferring globin levels in the peripheral blood. And that's demonstrated here, where you can actually see beta A T87Q that migrates separately from beta A from the blood bank that migrates separately from hemoglobin S. And so it does give us a measure of being able to very quickly see whether or not we're actually, when someone is doing better, are they doing better because, what the reason would be. Ideally, it's because they now are expressing high amounts of T87Q. And this is an overview of lentiviral or LentiGlobin gene therapy. And I will tell you today, this is actually approach for all gene therapies for the most part, in that we do hematopoietic stem cell collection following mobilization, for the most part with plerixafor, although we're getting a little bit more confident about a motixafortide as an additional mobilizing agent. But their cells are mobilized into the peripheral blood, they're collected by apheresis and then sent to a laboratory. In that laboratory, they're undergoing some type of manufacturing procedure. So in this case, they are CD34 selected, they are transduced with BB305, and then they are cryopreserved. They undergo a number of safety tests, and then they're frozen. They're sent back to the clinical site where the patient is then admitted. Now, during the time in between, these patients are back at work or back at school. Then they did a call to be admitted. They undergo myeloablation with busulfan over 4 days, 2 to 3 days of rest, and then they have their drug product, which is their modified stem cells reinfused. And then they remain hospitalized. That hospitalization today is more or less the recovery from the busulfan itself. But we also look for evidence of engraftment and then the production of cells. And that is either recovery of their platelet count and white blood cell count following myeloablation, but then also hopefully the production of red blood cells. And in this case, hopefully red blood cells that now have incorporated beta A T87Q. In the research studies, they were followed for 2 years, but then with the expectation that they sign up for a follow-on study for another 13 years, for a total of 15 years of follow-up. I will also tell you that that is the expectation now for people in the commercial space, that they are also followed long-term. These are the results of one of the clinical trials using LentiGlobin BB305. This is actually a swimmer's plot, and each one of these bars represents an individual patient who's undergone gene therapy. All of the red symbols represent hospitalizations for vaso-occlusive pain episodes in the 24 months prior to gene therapy, with time 0 being the time that they actually receive their cells back. And then the lanes moving out from there is a period after that. And you will see in this one that 32 of the 34 patients have achieved complete resolution of severe vaso-occlusive pain episodes in the time after they've received gene therapy, usually in a relatively short period of time, and that those who continue to have some symptoms have fewer hospitalizations and shorter hospitalizations, and so still some clinical benefit for those individuals. Another approach is a lentiviral approach, but it's going at it in a very different way. And this is using a short hairpin mRNA interference approach, targeting a gene called BCL11A, which is not a globin gene at all. BCL11A is one of the key regulators for the expression of globins, going from gamma globin in utero and in young babies to beta globin as adults. And so the thought being that if you could somehow silence gamma globin through BCL11A, perhaps you could then begin seeing the expression of non-sickling fetal hemoglobin. And this is work done out of Boston Children's by my colleague, David Williams. The first 6 patients were published a few years back, and what you can see is following gene therapy using their approach, these individuals maintaining very high hemoglobins without being transfused, high amounts of fetal hemoglobin, high numbers of F cells, and actually really a near elimination of hemolysis. And so really some amazing early work that has led to the phase 2 multi-center trial called GRASP that is now completely enrolled and will be reported out at the ASH meeting this year, but with some results that look quite promising. It's an additional lentiviral-based approach to gene therapy for sickle cell disease. Another approach using BCL11A involves gene editing, and this is the very first time that CRISPR-Cas has been applied to a human disease. And again, what it is targeting is BCL11A because as a transcription factor, it's responsible for the repression of gamma globin being produced. And so that if you can actually silence BCL11A, it will allow fetal hemoglobin to be produced because gamma turns back on. That is the principle behind this. And so they use an approach targeting the promoter region of BCL11A to turn it off and hopefully turn fetal hemoglobin back on. And these are the results of their study. Again, each one of the bars represents an individual patient journey. Each one of the blue diamonds is an admission for a vaso-occlusive pain episode. So these were really affected individuals with sickle cell disease until day 0 when they get their cells back. And then following them to see whether or not we see durable benefit in terms of the reduction or the elimination of pain episodes. And in this case, almost 94% of these individuals were also pain-free following this procedure. We'll talk a little bit about some of the complications because this is not by no means not without some risk, but certainly an extraordinary, for these to be 2 early studies, really extraordinary results. A third one that I think I'm certainly very, very excited about is one called Beam 101. And this is using base editing for the first time to essentially recreate the hereditary persistence of fetal hemoglobin. So this is a really unusual condition, a hemoglobinopathy, where these individuals continue to make baby hemoglobin, and they do just great. Even if they have actually co-inherited sickle, by and large, people who have S-HPFH are remarkably well. And so again, once again, the thought was if you could somehow convert someone from SS to S-HPFH, well, wow, we know that the individuals who inherit that are doing great. And so would this be an acceptable outcome for individuals? And so base editing involves using an adenine base editor to make a single base pair change that does not require a double-stranded DNA break. Because there is no DNA break, in principle, it should be safer. And so that is certainly one of the questions being asked with this particular approach, that if you're able to make a genetic modification in DNA without causing a double-stranded DNA break, perhaps this would be an advance for not only for sickle cell, but also for the field. And these are their results. And this is from the European Hematology Association, or the EHA meeting this past June. This is their first 17 patients. Again, patients who are fairly severely affected with frequent vaso-occlusive pain episode admissions in the time period beforehand. But then following it, none of their patients have had pain episodes since undergoing gene therapy. Now, admittedly, this is a newer program, and so the amount of time or the number of months since gene therapy is relatively short. But we continue to see this same experience, that we are not seeing individuals who are having recurrent pain episodes with this particular program. I'll call your attention to the third patient who died. This was an individual who had fully engrafted and had every evidence of actually seeing the therapeutic benefit, but died of pulmonary failure. There was likely a combination of busulfan as well as vaping. And we have definitely seen a couple of other individuals who have actually had pulmonary complications from vaping. And so certainly we are now really trying our hardest to be sure if there's any other reason to have people not vape. If you're undergo a transplant, please don't. But certainly that certainly is noteworthy in this particular program. What's also noteworthy is how rapidly people have gotten better in this program. Almost 40% of patients in this program have not required platelets following transplant, which we originally were very worried, like, did it work? If in fact your platelet count doesn't fall. But that seems to be something that we're seeing across this entire program. They recover very quickly, and most importantly, by 2 months, nearly half of the hemoglobin that they're making is fetal hemoglobin, and by the time they're 12 months out, the majority of their hemoglobin is hemoglobin F. And so it is not surprising that they actually are having fewer symptoms. Question is whether or not base editing is kinder and gentler to the stem cell, and is that part of it? And I think that is really one important question to be answered. But that, I think, right now is a working hypothesis on why is this so different. There are risks, as I've already mentioned, and a lot of them tied to busulfan. We do not think that today we can do gene therapy without myeloablation. I don't think we think that, and I think that there's also a small amount of data to say that it can't even be done with reduced intensity, although it may be worth exploring that one again. And so because it requires full myeloablation, patients see many of the predictable complications of busulfan, including mouth sores, hair loss, potential liver problems like veno-occlusive disease, pulmonary fibrosis, and the risk of secondary malignancies that comes from busulfan itself. We know that infertility is part of also the story with busulfan, but it also is a part of the story with sickle cell disease. And so certainly that another complication. Graft failure has often been something that we've talked about and we remain concerned about. Yet today, every single patient that I've treated and that everyone else has treated has an aliquot of their unmodified stem cells that is retained at the clinical site. On the outside chance that there's graft failure, you would return their previous aliquot of cells to them. Not a single person has needed those cells. Yet we still think of graft failure. We think it's still fairly early. The graft failure is still a theoretical consideration. Delayed platelet engraftment was seen in all the programs short of the most recent program with base editing, but certainly delayed compared to allo transplants. Clonal dominance or insertional oncogenesis is certainly something that we have to be mindful of when we are doing things that involve a double-stranded DNA break and insertion of any DNA. We certainly have seen individuals who have developed AML from the LentiGlobin approach. Suffice it to say, neither one of them can we attribute that to the gene therapy itself, that the insertion has not occurred in an oncogene or just upstream of an oncogene. At least in one of them, it occurred in their cells that actually were not exposed to busulfan even. And so we're not entirely certain. We know that the early cohort of patients that received LentiGlobin BB305 were oligoclonal, and we think that certainly is important, that any time that you are actually looking at delivering any chain and you only have recovery in a minority of cells, you are essentially setting someone up for oncogenesis because they are oligoclonal moving forward. Off-target gene editing has always been a theoretical concern with gene editing, and it has already occurred in a couple of the patients who have received exa-cel. Having said that, the gene editing that the off-target that can be detected does not seem to be clinically meaningful, at least in the short run. But again, I think the notion that we can't say that it never happens, it absolutely does. But at least for now, the off-target events that are occurring with the current iteration of Cas-based, the current Cas9 approach is still there. And then infertility is not trivial. And in fact, for some of my patients, they would just assume pass on our current versions of this because having families is so important culturally to them. In vivo gene therapy, I think, is the future. Lipid nanoparticles may very well be the delivery device, but it need not be the only one. But certainly this is work done by some of my colleagues at CHOP and Penn, looking at delivery of mRNA using lipid nanoparticles. And this is a proof of principle, both in mice and non-human primates, to be able to show that they can deliver the essentials for gene therapy in this way. I think that there are a lot of questions that still need to be answered about how do we do this and how do we do this in a way where we're reasonably confident that this will be sustainable. But to the extent that we can actually deliver this without using chemotherapy, without an extended hospitalization or allo transplant, this would certainly be a major breakthrough in this field. Having said that, the FDA, just prior to the ASH meeting in 2023, announced the approval of those first two gene therapies that I described, exa-cel from Vertex, which is now called Casgevy, and lovo-cel, which is BB305, now called Lyfgenia from Bluebird Bio, with fairly similar indications for older children and adults at least up to age 35, usually with the most severe genotypes of sickle cell, and the primary indication being, and you'll note the price tag, $2.2 million for Casgevy, $3.1 million for Lyfgenia. It's also worth noting that there have been a number of economic models that have been looked at, and sickle cell, I think it's safe to say, for those of us in the field know well, this is a very expensive disease to treat. And so suffice it to say, while I think these numbers are extraordinary, they still perform favorably when one looks at the expense of how much it costs to take care of sickle cell patients. I'm very hopeful in that as we begin thinking about using this in younger children, the benefit will be more profound because they will have a much longer lifespan to hopefully benefit from a durable therapy. But without question, these price tags have given people pause. And they've raised the question, once these new therapies are approved for use, will they be out of reach for some or for many? And this is not just a question for the hemoglobinopathies. In fact, just when these two were approved within a week, they were eclipsed by gene therapy for hemophilia B, which came in at 4.5 million. And there are others that are in a similar price range and clearly not sustainable for the US system or for any system of healthcare. But certainly in areas where healthcare is largely paid for by governments, this has become an extraordinary challenge for them to figure out how do we allow our citizens to take advantage of these, and how do we do this without bankrupting our countries? I bring this up because while we talk a lot about what's available to us in this country, just a reminder that sickle cell really is a global disease, and that if we do nothing at all, the global burden of this disease will increase by 30% by 2050. 75% of the children born with sickle cell disease will be in sub-Saharan Africa. They're primarily in 3 countries, and not just in sub-Saharan Africa. They are Nigeria, the Democratic Republic of Congo, and India. 90% of these children will not survive to adulthood. And in fact, the majority of them will not see their 5th birthday. So in this country, they have 1,500 sickle cell patients born every year. Just remembering there are 1,000 babies born with sickle cell on this planet every day. And it matters. It matters to families like this one, who have already lost 3 daughters to sickle cell disease. And the question is, will they lose their 4th daughter to this disease? Will advances in the diagnosis and treatment and cure reach those areas where there's the highest burden? Will they be left behind? And I think that efforts like the one that Ann mentioned, the Consortium for Newborn Screening in Africa that the American Society of Hematology is supporting, is one measure, and it's not the only measure, but really beginning to really look at partnerships across sub-Saharan Africa. Right now, that program is in 7 countries. But to begin looking at some of the same techniques that we're using for newborn screening in the United States to give children access to penicillin, immunizations, and malaria prevention to improve survival. Hopefully gene therapy will be available for them, but certainly those are going to be some of the fundamental building blocks that even in the United States led to changes in the outcomes for children with sickle cell. Sickle cell is a disease that truly represents disparities, and so I want to pivot to talk a little bit about that. I think that it's safe to say that in this country, it affects a unique population of historically overlooked, underserved patients who are often underrepresented, at least in this country. Not only do they have a medical condition, but the quality of life for them is poor, and they often do not have access to adequate health care. It's led one of my favorite colleagues, my colleague, Dr. Michael DeBon, to sort of posit that if sickle cell disease could be the canary in the coal mine, when we think about health equity, that there are so many ways that we could be impactful for sickle cell in ways that really could move the needle, could bend the arc for so many others. And so we have the opportunity to begin thinking about sickle cell in a way that would benefit far more individuals. And I always have to make a clear disclaimer. I have absolutely nothing against my pulmonary colleagues who have done amazing things with cystic fibrosis. Yet cystic fibrosis and sickle cell are a remarkable tandem. These are 2 monogenic diseases that we now screen for by newborn screening. There are some really interesting comparisons between the 2. There are 3 times more patients in this country who have sickle cell compared to cystic fibrosis. There is 3 times less dollars spent by the NIH for sickle cell compared to cystic fibrosis. The cystic fibrosis has really truly benefited, though, from a remarkable degree of philanthropy and goodwill for private donations. Private donations make up 70 times more than they do for sickle cell disease. And when we look at it per patient, it's even more stark. We also know that if we combine all classes of dollars, but both public and private, that there are still 10 times less dollars that are actually dedicated to sickle cell research. compared to cystic fibrosis. And so this represents our collective investment, at least in terms of looking for evidence-based solutions for this disease. It also has resulted in fewer papers being published for sickle cell disease. But this was data that actually is quite recent. This just came out in September in JAMA Peds. This is looking at data from the National Center for Health Statistics, looking at between 2008 and 2023, individuals with sickle cell disease at the top and cystic fibrosis at the bottom. And what we can see is we have clearly bent the biomedical arc for cystic fibrosis. That over this relatively recent period of time, that we can see that overall mortality from cystic fibrosis has declined in a period of time. With sickle cell, we're still seeing it rise. We've also looked at life expectancy, and for the first time, there's a cohort of cystic fibrosis patients that are dying of old age. We do not have that luxury thus far in sickle cell disease, but certainly represents the possibilities with the right investments to really see substantive changes for a condition that truly, I believe, deserves our attention. One group that I think has really attacked this has been the National Academy of Medicine, which convened at the request of the NIH and ARC, a really extraordinary group of individuals to come up with a strategic plan to really inform what should we be looking at in terms of trying to actually improve outcomes for sickle cell disease in a very concrete way. This is about 500 pages, but the executive summary is about 45 pages. And I encourage anyone in this space to consider looking at it, with the vision being to look at long, healthy, productive lives for people living with sickle cell, as well as those with sickle cell trait. And they proposed a number of different strategies, largely targeting academic medical centers, nonprofits, medical societies, really anyone who's funding research or drug development, looking for opportunities to make a difference in sickle cell disease. But one thing that was noted by this amazing panel of individuals who put together this particular document was something in the executive statement summary, which stated that improving health outcomes for sickle cell care requires comprehensive team-based care, new payment models, and addressing institutional racism in healthcare. Sources of systemic inequities and structural racism, I think many of us maintain the lens of healthcare, either between hospitals, academic medical centers, pharmacies, and clinics. I don't think that it's a surprise that that these can be sources of inequities that patients appreciate. What's important, though, is to look at the much broader view, and that is of the patients, where there are instances of systemic inequities and structural racism that actually extend far beyond healthcare, and then in many ways continue to be some of the things that continue to impact outcomes for the same people who are affected by diseases like sickle cell disease. It's also worth noting the National Academy had an additional report that came out in December 2024, commissioned also by ARC and NIH, asking what continues to hold us back in terms of healthcare inequities in this country. And they had a number of sobering, overarching conclusions. The first being is that the nation has made little progress in advancing health equity. Racial and ethnic inequities remain a fundamental flaw of the U.S. healthcare system. A diverse health and science workforce that's representative of the community it serves is essential. And that there are emerging approaches to achieving health equity which show promise and are poised to make a difference, but they will require increased investment on implementation and expansion. Continued research and evaluation are needed to ensure and drive improvement in health and health equity. So in summary, we've made some significant progress with sickle cell. And so it's really been extraordinary for me to have been in the space in medicine at a point in time where I think without question, the number of things were available for me when I was a trainee, what's available now are extraordinary. I don't think that anyone can deny that, especially in the last decade. Curative therapies, which initially were considered to be solely experimental, are no longer theoretical. Bone marrow transplant is now established for sickle cell disease, and there are some additional refinements that I believe will continue to make it safer. The early results for clinical trials with gene therapy and gene editing are promising. Now, the uptake has been relatively slow in terms of the commercial use, which we can talk about. But we need to focus also on achieving better outcomes by addressing health disparities because they persist. More education, increased awareness about sickle cell is needed, including more doctors who are knowledgeable about sickle cell. Not only more classical hematologists, but I dare say more primary care physicians, more obstetricians, more orthopedic surgeons, more radiologists, more you name it, are needed to improve outcomes for sickle cell disease. And I will end with a final thought, and and this is what Stan definitely in mind, because there are so many in this room whose lives that he has touched, from whom he has mentored, who I believe the statement actually applies to, that in order for us to achieve health equity, we need leaders who first care enough, and Stan had that in abundance, who know enough, and there are some brilliant individuals in this room, but who have the courage to do enough. Leaders who will persevere until the job is done. That I'll thank you.
Oh, thank you very much. We typically go to Q&A next, but because of the extra time we want to honor Dr. Schrier, we might jump to that. And we usually spend the last 10 to 15 minutes for time to mingle before everybody runs back to their, so I'll ask Dr. Gottlieb to come up next.
Just wanted to thank Dr. Thompson for an absolutely brilliant lecture. And we wanted to take this moment on behalf of the Division of Hematology to present you with this award, not only for being the inaugural speaker for the Stan Schrier Commemorative Lecture, but really for your transformative work in sickle cell disease and hemoglobinopathies and for being a global leader in hematology. So thank you for helping us pay tribute to Stan.
Thank you so much. Really, it was really a pleasure to come out and meet with you. It's there are times when it's like, gosh, there's so much to be done, and so much of it is going to be done in rooms like this with people who are gathered in rooms like this. So I'm happy to answer questions.
What we'll do is we'll ask people if they mind coming up. We usually end around 12:45, and so we're perfect timing right now. And so thank you so much. I just want to add, I'm not a hematologist, but my most memorable times throughout these years at Stanford has been from Dr. Schrier training. And after that, I still go, he'll be happy to know, I still go to the microscope despite not being a hematologist to look at the CBC. And I learned it all from him. So thank you so much for helping us honor him.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.